Welcome to Healthcare Rounds. I'm your host, John Marchica, CEO of Darwin Research Group. Today, we're joined by Natalie Baggio, Regional President for Southwest Michigan at Corewell Health. Now, Corewell is one of the largest integrated health systems in Michigan and really operating at a scale where regional leadership is very, very important. So today, we're going to be talking about balancing local priorities with system-wide strategies, confronting access and workforce challenges, and then also thinking about, or maybe even rethinking, how healthcare gets delivered to both rural and suburban communities. So with that, welcome, Natalie, and thanks for coming on today.
Yeah, thanks, John. I'm glad to be here today.
Well, let's just start. I'm sure your background is going to come through as we're going through these questions, but I think this is, thinking of the last one that we did, this is really interesting to get a regional perspective, especially how that sort of ladders up into overall perspective. So my first question is really how you would describe the mission and say mandate of a regional president and how that fits into the overall Corewell mission.
Yeah, I think Corewell at large, we have a really great visionary strategy, and we're investing in how healthcare evolves over time, and knowing that we have lots of different competitive landscape right now in healthcare. I think our overall strategy and our 5 pillars are going to really propel us into the future in a very strong stance. From a regional perspective, we're dealing with things locally that most people across the nation are dealing with. And Southwest Michigan is a very rural part of the country. And a couple of our largest areas that we're focusing on is access to care and workforce stabilization, which is not unique to our position today.
Sure. And we're going to get to those. But so if you think about it from a regional perspective, what are your top, say, 2 or 3 regional priorities, and how do those ladder up? I find that this is a fascinating issue, and a lot of health systems are always dealing with this, right? So what's most important, as you said, in your particular region, and then making sure that fits into the overall strategy. So your top 2 or 3.
Yeah, when we talk about access to care as one of our top priorities and challenges, we're thinking through that as like expanding our ambulatory footprint and having an ambulatory strategy, forward strategy, and also evaluating key service lines based off of market needs and demand. And how we're thinking through that and how that impacts the system is because we know like transform is one of our pillars of our strategy at the system level. But in order to achieve some of the access pressures and demands, we have to think through that lens of how do we transform our care models today to achieve our targets and our goals. Other areas that we're really focusing on is workforce stabilization. And part of that stabilization is transforming not just how we deliver care today, but also how do we inspire other people within our communities to choose healthcare as their profession. And we put things in place like pipeline programs to help inspire our communities to invest their time and effort into thinking about healthcare as a career.
Tell me a little bit more about that pipeline programs. What does that means? A lot of things. It could be a lot of different things. What does that mean in this context?
Yeah, so we've had pipelines here locally for almost 3 years now. And the way we've thought through this was first internally, and now it's progressed externally. But it's a community partnership. So it's Corewell Health, our academic partners, and some of our other key partners in our community that help evolve career pathways. And so it's been bringing people together, creating that vision internally and externally to make career pathways a possibility, and then managing those programs from a community perspective for success. And what we have something that's kind of unique here locally. So once we have people within the community that enter the programs, we employ them and we put them through some official and unofficial style apprenticeships to where they're categorized on this career pathway. We know exactly what they're going through. The program is branded, and some of our programs even have built-in stipends to help people balance school, family, and academics along with their work professional growth. And part of the programs internally are real-time work experience. So people feel more prepared to enter their workforce into that dedicated profession once they're graduated from the program. And we're proud to say we've had 85% graduation rates over the course of the last 2 years into our program. It's continued to mature.
Wow. So I'm thinking about, one of the issues that we talk about a lot, that's written about a lot, and that's burnout. And kind of having, when you think of the quintuple aim, that joy in work kind of being part of that and reducing burnout, how has that program improved or affected and burnout? And have you been able to measure any of that success?
Yeah, I mean, we look at specifically through our Glint surveys, we look at how our teams are feeling and scoring their burnout, their investment, how they feel that they belong to the company, do they feel close to the mission. And we were very proud to be able to announce that we were at a 70 engagement score this year, which is really, it's 3 points. We shifted 3 points, but we've also done really well according to like national standards and benchmarks in that area. I do believe that by providing programs where people can see career advancement and growth, that in return helps with retention. And when you have retention, a more stabilized workforce can in return help with burnout. But what we've been able to do also, like close to burnout, thinking through like the prove and transform pillar of our strategy is technology and innovation. And to really address burnout specifically inside the hospitals is thinking through that lens of technology, but also how do we give back through innovation to our team members? And we know one of the things that keeps people inspired is where they can feel more autonomous in their work. So layering in flexible scheduling and enhancing technology around how people can choose schedules that work more aligned with their personal life, but also bringing technology in-house that we partnered recently with the American Heart Association and launched an RQI to where it allows people to maintain their competency on resuscitation quality improvement for their BLS certification, to where they can do this on a quarterly basis, but on their own time. So we have stations set up all across our system to where people can go and maintain their competency and their BLS certification. So they're not having to schedule time outside of work to attend a class routinely. So we're thinking about those types of innovations that give autonomy back and also then in return reduce burnout with our team members.
That makes a lot of sense. I want to go back to just the decision-making process for a second. And I feel like rather than a podcast question, this feels like a typical market research question that I would ask, but I'm genuinely interested. And that is, you have these we start out talking about the pillars or the 5 pillars. Is that what you said?
Yes.
Right.
Yes.
So what is the process like when you identify a local initiative, how the decision-making process works, how you bring that to, say, national or rather, the overall Corewell management team at corporate, and I guess what I'm trying to get to is the bottom-up decision-making around that versus the top-down, and how that really works at a kind of like an eye level. How does it work day to day? Because it's one of the things that I have seen in studying these health systems over so many years is there's always seems to be this disconnect, no matter how well the system performs, right, between the local needs and what sort of management says is most important. So what is that process like for you?
Well, I think it's evolving. Ideally, everything rolls through a governance structure for final decision making and approval to execution. When I talk about something like RQI, I mean, there's a lot of different sectors of the organization that have to intercept in order for something like that to be launched. But RQI is an example of nurses, frontline nurses and education team from one of our unit councils that brought this idea forward. I'm a true believer that the best ideas come from the people that are closest to the work. From a system level, we're working through how do you set up those structures to where those voices are heard, and then we can take action based off of recommendations, and not just action, but action that turns around quickly. Because as healthcare systems merge, grow, there is that challenge of how do you hear people's ideas and turn it into action, but in a timely turnaround, because there's a lot of competing pressures. And we have made a lot of great advancements here at Corewell on system governance structure, but we're continuing to evolve at this point in time. But our commitment is for people closest to the work to have the strongest voice that bring the issues forward and the solutions.
Makes sense. Well, let's talk a little bit about rural health, because I know that's something that you're dealing with, right? And you had said that there's your part of in Michigan that you're focused on. Can you give? This kind of goes back to the decision-making process, but can we walk me through an example? You talked a little bit about around career and things like that, but an example of a local initiative that succeeded, hopefully, but then also maybe got more of a system-wide exposure after you had implemented something locally.
I think a couple of things I could speak to, but one thing I'd really like to share that is new and is in a pilot phase just here locally is our virtual reality education. When you think about rural health specifically, you always think through how do you have the right services and scope of service, but then support the people doing the work to have the right level of competency and exposure to different types of procedures or interactions that you may not see on a routine basis just based off of where you're geographically located. So one thing that we are proud of that we're able to pilot right now is a virtual reality education that simulates different surgical procedures with our frontline peri-op team members. And we feel that this is going to be a great way to how you merge virtual care and competency, but also the comfort level on a procedure that you may not see on a routine basis. And this is something that's unique to the region in which I lead, but also something that we're looking at across nursing and other allied health professionals at the state and system level.
So when you say virtual reality, are we talking like glasses over the face kind of thing? Really?
Yes. Where you can hand like the right instrument if you're a scrub, or based off of whatever your role is during that procedure, you can interact and then you receive a score on your level of competency during that procedure.
So fascinating, right? But how are you measuring then the results? Is it improvement in scores? Is it because it kind of feels like a flight simulator, right?
Yes, it kind of is. It's very similar to that, actually. And there's an entire analytics platform that goes along with this. So we can see by team member how well they're performing or where their areas of vulnerabilities are. We have people that might engage and want to do something that's newer in their career, and they just want more experience, like in ortho or neuro or other areas that they may not practice in regularly. And then they have that opportunity to see new equipment or experience the procedure without actually being in the intra-op space at that time.
So what's the uptake been like? How has it been received? And now that you're in the pilot phase, of course, but how has it been received?
Well, as any sort of new innovation, you have early adopters and late adopters. And
Right.
um, right now, we've been doing this for about 4 months, and we've had some people who really engaged in it and felt very comfortable with it and have done really well. And then we're still working on bringing new people into experiencing the technology. I think if you ask me in 6 more months, I'll be able to give a much more detailed analysis. But I think right now the feedback early on has been really wonderful, and people are excited about it.
Well, I love the idea that you had that, especially, as you said, things that they might not see all the time, but being able to practice that and know it in advance. Again, back to the flight simulator, you're testing all different kinds of things that could go wrong that hopefully you never see, but you have the opportunity to practice that, and it makes a lot of sense. So maybe we
Yeah,
come
and I
back, we can have you talk about it more.
right. I
Go
would
ahead.
love to. And I think in healthcare in general, when we're thinking about how to do things differently and transform care, we have to learn from other industries of what has been successful. How have they maintained positions where people could practice at the top of their license? And we've talked about that a lot in healthcare, but specifically when we think about rural healthcare, we have to invest in how to allow our licensed professionals, especially, to be able to work at the top of their scope and the top of their license, because that's how we maximize access to care and ensure that we are able to deliver top quality care that's not at risk or has vulnerability based off a geographical location.
So you talked about a little bit about workforce and training, and then we've got this virtual reality, which sounds really cool. But when I think about kind of typical rural issues, tend to be around transportation. You mentioned access, the access to technology, access to care, just in general. So when you think about your area, what would you say is the most pressing issue for rural care? And maybe the follow up to that, Natalie, is what have you done about it? What
Yeah,
know that that's a big issue. So
that's a
how
great
have you addressed it?
And I would say a couple of things. Transportation is definitely an issue locally here in Southwest Michigan. And we are working with a consortium on how to address that transportation. I would say another big issue when I think about retaining and recruiting people to Southwest Michigan, housing is a number one issue in that capacity. And we have been investing in housing. A couple of things that we're doing, and I do believe, and I know this, like economic growth there's a direct linkage to the strength of the healthcare. And for that reason, myself personally and my local executive team, we're engaged with economic development across Southwest Michigan, and not only sponsoring housing initiatives and housing studies, we're building workforce housing. And we just built our second phase of our workforce housing that is in flight right now and will be finished this summer. And then we're looking at our next location, which will be in our South County market, close to Niles, Michigan, where we'll continue to build workforce housing. And this is not just unique here for us, but Corewell in general is investing in workforce housing across the state because we know that this is one of the biggest challenges. And if we want to bring more people here to Michigan, we have to make sure that we have a great place for them to live, but also a great place to work. And that's why and play. And that's why it's just important that we stay engaged with our community partners.
So that is a nice segue into my next question, which was really about partnerships, understanding you can't do all of this yourself. Um, what are some, in your view, some of the most successful partnerships that you've been able to accomplish or to execute in your time and your role?
I'll speak to access to care. We have areas here in Southwest Michigan that we do not have bricks and mortar today, but we know we have people and patients in our communities that need access to care. So mirroring that access to care challenge, the transportation challenge, we worked closely with one of our partners called Cass Family Clinic. It's an FQHC in Southwest Michigan, and we launched a mobile clinic this summer. And we are working to take that mobile clinic into communities today that do not have bricks and mortar to allow access to care, to primary care, to lab, to behavioral health services, as part of a strategy in order to accomplish our mission, but also to strengthen our partnerships, because we know we cannot do this alone, that we have to bring people together with a vision and a common mission to be able to truly execute on what we want to accomplish with healthcare. And especially in a rural space, it's paramount.
So you mentioned primary care, behavioral health. When you're thinking about access issues, do you sort of start with the population and say we've got to address this particular issue first? Or do you think about service line, or do you have to kind of marry the two? It sounds kind of like the latter, but how do you think about access? Is it more in terms of service lines or populations?
It's actually in parallel with each other. First and foremost, early last year, we started a market analysis, so quantitative and qualitative. And then we looked at our services and our geographical footprint. And our strategy is really outlined and will be executed based off of what the community needs and what they want. And a lot of it is in ambulatory care, specifically in primary care, but it's also in key service lines. And that ambulatory footprint makes such a difference in people's day-to-day lives that we have to think about those two in parallel. Because if you get in to see primary care, but you need a specialist, but you don't have the specialty service lines built up based off of the market needs and the community needs, we're still not going to be able to deliver the right level of care. And for us specifically, being part of like larger system like Corewell Health, we're able to invest in pathways to where people can have specialty care more seamlessly and be able to refer, even if there is that transportation barrier, but we can refer people so they can get the right access to care with the right provider. We have a long-term goal on what we believe our community needs, but it's going to take several years to get there. But I'm really proud that we're with a company like Corewell Health, where we can have those bold visions to deliver the right care in the right communities.
If you had to choose, let's say, one patient population that is particularly challenging, in terms of delivery or some of the things that you've been talking about, what is that population? How can we think about that? And then how would that be reflected maybe in other parts of the country? Just curious how you prioritize that.
Yeah, I think for us in general, when we think about health, we think about how to prevent disease as well. And some of the areas that we've been focusing on in preventative is like colon screenings and things like that. But when you have a national shortage and a local shortage of gastroenterologists, we start thinking about how do you build those service lines that help prevent future disease in our patient population. So one of our main areas of focus right now on recruitment and retainment of a service line is gastroenterology.
So in practice, I'm sorry, I'm getting into the weeds here, but I'm just curious, like in practice, what is that being able also to leverage the overall Corewell presence? Does it mean you're adding in teleservices? Obviously you can't do, telecolonoscopies, right? But how does that fit in with the transportation? Or are you looking to things like, what is it called? Cologuard or things like that being able to get it into that rural population? Maybe they're not going to be able to get a colonoscopy tomorrow, but something like that might work better.
This has been a great example of transform for us in rethinking our care model. So we had a legacy care model where physicians rotated through clinic and did procedures in the hospital. And we've reevaluated that, and we've brought in proceduralists and also gastroenterologist hospitalists. As new physicians are entering the workforce, they're looking for a different type of commitment to the work and a work-life balance. So we have been able to evolve the way we think about our care models to be able to increase our access. And yes, we've used things like Cologuard and other new innovations and technologies to help screen patients more timely. And then in return, that helps us prioritize and triage patients that are coming in and needing to see physicians, specifically in the office. Other things we've done is we've hired up our mid-levels, and we're allowing them to work to the top of their license and work in direct collaboration with our physicians that work in the hospital and outside of the hospital. So we've made a lot of progress in this service line over the last 16 months, but we still have a considerable amount of work to do to meet the community demand.
Natalie, this is a last question, but it could be a big one. We haven't hit it yet, but I want to talk policy. Mm-hmm. And just thinking about in rural health, there's been so many changes over the last year. You say over the last 5 years, but certainly there's been a lot of disruption coming out of Washington. And so I'm just curious if there's one policy that you've seen that's having a very positive or negative effect on rural care, and if you could sort of wave the magic wand and change it and create new policy, what would that be?
I think two things. First, I think having policy that really encourages our communities to embrace prevention. And secondly, virtual care would be my second area of focus. Even today, at a national level, it's really challenging to recruit enough providers or train enough physicians and nurses to meet the demands. And we have to think about how to leverage technology like virtual care to meet the demands of our communities.
Excellent, excellent. Well, I've got some lightning round questions, but before I get into that, because we're about ready to wrap up,
okay.
Just what advice would you have? We started out talking about the regional versus the corporate and all of that, but I know that we have some regional leaders that are going to be listening, health system leaders. What advice would you give them just in terms of what works in communicating with sort of corporate, and what's most important to be thinking about if you are that regional leader? What advice would you give?
I think as a regional leader, what I really focused on internally is how strong our culture is. Because we've talked about this a lot around burnout, retention, bringing new people into healthcare. I think it's really important as a leader to ensure that you're embracing a culture that cultivates trust and transparency and authenticity. And in the return, you will have a much stronger team to deliver on the demands of the community. I think as my position and my role, I stay connected internally and externally. It's really important to know what the community needs and how they perceive their health care. And how do you work in tandem with other community partners to fulfill that mission and achieve the goals that the community needs from us? I think that's been really important. How do I connect that back to the system is being very clear, but also curious. You know, when you think about large scale strategy, you have to, as a leader who represents a region, you have to be able to have a curious mindset, ask the right questions, but also be very clear in what you're hearing from the teams and the communities that you're representing.
Well, that also kind of goes back to transparency, building trust, being authentic, right? I mean, it ties into those things as well. All right. Well, so I like to finish, I always like to do a lightning round. So these are just one word or phrase. I'm going to read off these different questions and then just top of mind, right? What comes top of mind? So most underrated challenge of rural healthcare.
You know, I think maybe the most underrated is there's so many people here locally that have the passion and the inspiration to really come together to build a bigger vision. And there's just so much horsepower when you bring people together in a smaller community.
What's a healthcare role that you'd like to shadow for a day?
Actually, I've been doing that. I've been doing day in the life of individual team members, and it has been really, really inspirational to me. And I have learned so much from supply chain to registrars. One that I have not shadowed that I think I might want to shadow is like someone who works in food and nutrition.
Interesting.
I have a family background in the restaurant business, and I really enjoyed that. But I've actually never followed or shadowed anyone that delivers food within healthcare, and I think that would be really interesting to learn about.
The metric that you check most often?
I probably check most often my quality scores. I look every day on the number of patient falls.
Excellent. And finally, one book or thinker who has shaped your leadership style?
There's been a few, actually. Stephen Covey was like one of my first leaders that I learned a lot from. But I would say like Carol Dweck, her mindsets has really helped me think about how to work and lead with different people and with different philosophies. I've always learned a lot from Mel Robbins as well, and how she helps inspire you to let go of the things you cannot control, but be your best and authentic self.
I'm just curious, the Covey, you mentioned Stephen Covey at the start. Yeah. Is that in line with some of the trust?
Yes.
The work on trust? Yeah.
Work on trust, the seven habits of effective leaders. Yeah.
Yeah.
Kind of foundational, like tried and true classics.
It's funny. I read that stuff and it's like, oh, this is common sense. Well, yeah, but do you actually practice it? Right?
That's exactly right. And I say that a lot. I can put anything on paper. I can give you any type of presentation. I can tell you what I'm going to do, but I want to show you how to do it and what we're accomplishing.
Well, Natalie, this has been great. If anybody wants to reach out to you, what's the best way for people to find you?
They can find me on LinkedIn or my email.
Excellent. All right. Well, thanks again. That'll do it for another episode of Healthcare Rounds. A big thank you to you, Natalie, for joining us and giving us a deeper look into regional healthcare. And if you enjoyed today's discussion, make sure to subscribe on Apple Podcasts, Spotify, or wherever you listen. And if you're interested in more conversations like this, please check out past episodes at darwinresearch.com or again, wherever you get your podcasts. I'm John Marchica. Thanks for listening, and we'll see you next round.